Good evening, everybody, for yet another interesting session on no thrombosis, where we discuss case studies regarding stroke. So, without further ado, I would just like to welcome everybody today evening for this KT, or as known as no thrombosis. Could you go to the next slide, please? Today we have an esteemed panel here with us, and it's a pleasure to welcome our course director, Dr. S. Meenakshi Sundaram. Sir definitely doesn't require any introduction from our end. It's a pleasure to have you here, sir, today. Sir is a senior consultant neurologist at the Apollo Specialty Hospital, Madurai. Sir has more than 2 decades of experience in neurology and has participated in research work at various workshops in the neuro department, published various papers as well. Sir is directly associated with the Neurological Society of India, Indian Academy of Neurosciences, American Academy of Neurology, and has had various achievement awards, had like the gold medal and the best outgoing student award for the year 2000 at Bangalore, and also the best research paper awarded at the 10th annual conference of IIM Lucknow in 2002. Sir has 29 journal publications and 18 book chapters. Sir, it's a huge pleasure to have you here, sir, today with us, and we look forward to your active participation and clinical insights in this meeting.
Thank you, sir. Thank you.
Next slide. Yeah. With this, we also have our esteemed moderator, Dr. Malamurugan, sir, from Salem. Sir is a senior consultant neurologist, and he's also had neurologist here under his MBBS, MD, and DM. Sir has had a gold medal in MD in general medicine, and also was having the best paper award at the Association of Physicians of India. There is a Teaching and Bar Excellence Award 2021 and the Best Faculty Award as well at the Indian College of Emergency Medicine in 2003. Sir is the chairman of the Association of Physicians of India, Tamil Nadu branch from 24 to 25. Sir has been contributing as an author in textbooks of emergency medicine, practical neurology, and neurological examinations and many others. He has more than 25 publications under his name and has been a guest speaker at more than 100 such lectures in the national and international conferences. Sir is a course director of the Fellowship in Neurological Emergencies by the Indian College of Emergency Medicine. So we welcome you here, sir, today for this no thrombosis workshop of ours. Could you go to the next slide? Yeah. With this, it's also a pleasure to invite our second moderator, Dr. K.K. Pritchett. Sir is an MBBS, MD, and DM neurology and a senior consultant neurologist at Coimbatore. Sir is a well-renowned neurologist with more than 25 years of experience in this area. Sir has a specialty when it comes to demyelination, stroke, etc., and has been working at Coimbatore since. So it's a pleasure to welcome you, sir. Yeah. Next slide, please. Please take Krishna. Can you? Krishna, go to the next slide, please. Yeah, and it's a pleasure to welcome our speaker, Dr. Kuhan Ramamurthy again. Sir is a senior consultant neurologist at the PG Institute of Neurosciences and Neurorehabilitation. Sir is a senior consultant there and an associate editor of the Journal of Indian Federation of Neurorehabilitation and assistant editor at the Journal of Indian Stroke Association. He has had more than 45 publications and achieved various awards like the President Gold Medal in DNB Neurology. He's a professor A.B. Srinivas Gold Medal as well in neurology, and is contributing author in South Asian editions of the GDOM's neurological examination, portraits, etc. In the practical neurology as well. So, sir, we welcome you today for this wonderful session on just like Dr. Sundaram to please
terminology stroke by stroke. It is individual cases which give us insight. And with that, I also would like to welcome my two moderators. We all share the same platform when we are doing our DM residency in MIMS. And both of them happen to be good teachers for me. I learn every day from them, from our speakers, Dr. Gugan Ramurthy. Age, he is junior to me, but I can assure you that he is one of the best teachers I have ever had. I had the pleasure of listening to him for a whole year, and I'm actually waiting to listen to him once again because I've learned his talks 1 full year. I've learned from him. Thank you, Gugan, for joining us. And without much ado, I pass on the mic to my moderators if they have comments to give, and then we can go on for the talk. Balmurugan and Prachet, your comments before we start.
No, I think we will start straight away. No problem. Waiting to hear from Dr. Guhan.
Balmurugan.
Murugan has not yet joined, I suppose.
In which case, we can learn from Gugan. Gugan, the stage is yours. Please come and enlighten us, please.
Good evening, everyone present here. I sincerely thank the organizers for giving me this opportunity because it is a great honor and pleasure to present in front of my teacher, Dr. S. Meenakshi Sundaram sir. It in fact feels like an exam for me presenting a case scenario before sir, and my palpitations and heart is already racing. Please pardon me if there are any mistakes, sir. So with that, I also thank Dr. Balamurugan sir and Dr. Prachet sir for guiding me in this presentation today. So with that, we will go into the presentation without wasting any more time. So today I chose the topic of the stroke without the clock. So the stroke thrombolysis among practitioners has pervaded far enough into the rural areas now that the window period of stroke is now nailed in everyone's brain that it's 4.5 hours. And once the patient presents within 4.5 hours, thrombolyze him if there are no contraindications. And we are moving towards an era of smart thrombolysis wherein we are reducing the contraindications. So if a patient is going to present at 9 a.m., his clock is ticking till 1:30 p.m. Though we have our own reservations for beyond the 1:30 p.m. when we are crossing the 4.5 hours timeline. But here we are going to look into the stroke without the clock where we do not have the time ticking for us, but rather the neuron ticking for us. So we are going to look into wake-up stroke. So this was a patient, a 58-year-old male who sells ice, and he is known for lifting heavy blocks early in the morning at the dawn when the air is cold enough. And he wakes up one day where he is unable to lift his left arm. He tries to get out of his bed, but he is unable to stand on his legs as well. His speech was slurred. And he immediately wakes up his son, who is lying beside him on the floor. And he recalls him that he went normal to the bed last night and he has now woken up. So now we have no clear onset in time. So whenever a patient has a wake-up stroke, the first thing is, by convention, we take the window period as when he was last seen normal. So this patient who went to bed at 10 p.m. now gets up at 6 a.m. with a stroke. Now we label him as he was last seen normal at 10 p.m. So now if he is going to present to me, even if it's a 7 a.m. time, then I'm going to label him out of the window period. And most of the time, by convention, by routine research protocols, he is exempted from IV thrombolysis. So what are we going to look today is wake-up stroke with unknown onset time, and how are we going to find the window in these patients, and what are the treatment that we give, and if any complications that resulted in this case, and what are the lessons to learn, because as SMS sir told, we learn stroke by stroke from every case. So what's with this wake-up stroke is that it definitely represents a challenge, because 20 to 25% of all ischemic strokes, though data may vary, there are some research which says it's actually 15 to 25%. It constitutes the wake-up stroke. Now we are upfront excluding 1 in every 4 patients from thrombolysis. Is it good to do that just because we are ignorant of when it started. So we actually are looking into what can we do for these patients to find out if this patient has still a window of opportunity for thrombolysis when there is no clear time of onset, and not exclude them from IV thrombolysis. Is there a treatment window, and can we change his life? Because in fact, if you look into when the stroke occurs in these patients who presents with wake-up stroke, 40% of them actually had their stroke when they were actually getting up from that sleep. 60% it would have been 1 to 8 hours before waking up. So actually 40% of them, we are ignoring them from thrombolysis. So what can we do for them? So this is our patient. In the emergency room, his NIHSS was 10, left arm and leg weakness. Arm was 0/5 and leg was 3/5. And there is a left facial palsy with dysarthria. Here, the problem was not recognizing the stroke, but the problem was the timing. And are we too late? And how do we determine if this patient is eligible for thrombolysis?
Hare Krishna, yeah.
So here we are asking the patient to lift the left arm. He is unable to lift it. Now we are now he is trying to lift it. It's ill sustained against gravity. He is able to lift the right leg. And he is able to he is able to lift the upper limb. So for him, the stroke onset, at this point, there is a sudden restriction in flow. And what is the traditional timeline that we look into is a 4.5 hours. But if we split it into further windows, the first 90 minutes has the best recovery compared to the 90 minutes to 180 minutes, and 90 minutes to 180 minutes has a better recovery than the 180 minutes to 270 minutes. So we are actually having a conventional window of 0 to 4.5 hours. So actually we don't wait until the clock strikes 4.5 hours. Rather, we have a golden window of opportunity in the first 90 minutes when the clot is going to melt like ice in the sun. Nevertheless, we also have an extended window where we can take up patients for thrombolysis beyond the conventional window, like in cases of wake-up stroke or in those strokes when the patient actually do not know when they had their onset. And this extended window can be also applicable to mechanical thrombectomy when we are going to take it up for up to 24 hours. And this is based on the Dawn criteria and diffuse 3 criteria. That's for 6 to 16 hours. The conventional window for thrombectomy is going to be up to 6 hours where the door to needle time is. But beyond the 6 hours, we are looking into an extended window using the Dawn criteria and the diffusion criteria, which is actually going to tell us that the patient might improve from thrombectomy. So as we all have seen earlier, to a quarter stroke is going to be a wake-up stroke where we don't have a clock ticking, but rather the neurons are ticking. So as we have seen earlier that we traditionally label these patients are ineligible for IV thrombolysis, but with improvement in imaging, there has been a shift in what we call the time window to now the tissue window to see if these patients are going to improve. So here we did an MRI for this patient to find the tissue window. The one in the center is the diffusion sequence, and this DWI actually shows a diffusion restriction in the region of the superior division of the middle cerebral artery on the right side. And there's no flour change, but if you look into the angiogram, there is an occlusion that's noted in the M1 segment of the middle cerebral artery. Though this supplies a larger area, only a small area of it has undergone a cytotoxic edema as of now, but there is no changes in the flour. So whenever this diffusion sequence, whenever there is a stroke, there is an energy failure. And this energy failure will result in fluid, a cytotoxic edema being accumulated within the cells. This results in restriction of movement of water molecules. And in imaging, we detect it as a diffusion restriction. And this diffusion restriction denotes the stage of a cytotoxic edema. When this ischemia is going to progress further and further, there is going to be a disruption of the blood-brain barrier, And this disruption in the blood-brain barrier is going to result in vasogenic edema. And the one image on the left, that's the flare image, helps decipher if there is a vasogenic edema in this patient, because once vasogenic edema occurs, even if we thrombolize and recanalize the vessels, we are going to have more side effects than benefits for this particular patient. So here we do not know the time, but we have the tissue window that there is a cytotoxic edema, but we do not have a vasogenic edema as evident from a normal flare image. And thereby, if I am going to restore the blood flow to this tissue or the vessel, this is going to result in a better functional outcome for the patient. So what's with this biological clock? That's the DWI flare mismatch, is that DWI has to be positive, flare has to be negative. If the flare is positive, then we have lost the biological clock, the window of opportunity, and therefore we will not be able to thrombolize him. So now how effective is this DWI flare? Effective in predicting the time window. That is, if a DWI flare is mismatched, how sure am I that this patient is presented in the first 4.5 hours? So the specificity is 0.78 or 78%, and a positive predictive value that if there is a DWI flare mismatch, that I'm right 83% of the time. But what we are looking at here is we are not trying to label if this patient is a time window, but rather we are looking into the tissue window. Because now we are going not just by time, but pathophysiological mechanisms where we are trying to address the vessel when the cytotoxic edema has developed and the vasogenic edema has not developed. We know the pump has failed, but the blood-brain barrier is intact. If the pump has failed and the blood-brain barrier is intact, if I'm to restore, there is going to be energy restoration and the cells are going to return to normalcy, or there is going to be an improvement in this patient. There is going to be an improvement in the functional outcome. But if there is a blood-brain barrier disruption and I am going to open up the vessel, then it's like opening up waters in a broken dam, and that's going to result in more injuries than benefits to the patient. So here in DWI flare, it is a tissue window that we are getting in these patients. And in fact, those patients who even present with a time window, if there is a DWI flare mismatch, then there is a chance that this patient might not improve with thrombolysis. So what are the other criteria that we have? We can still find the tissue window using CT perfusion. But in CT perfusion, the relative cerebral blood flow, less than 30% identifies the infarct core. And we have another measure, that's the Tmax. If this is more than 6 seconds, then this identifies the penumbra. So if there is a mismatch between this core and penumbra, then we label it as we have a tissue window. The perfusion diffusion mismatch is what we apply in the MRA again. These are the parameters that we follow. Most of the trials have used the DWI flare mismatch. That's easier to apply, but that has high inter-individual variation, because what might appear as a flare normalcy might appear as a flare hyperintensity on adjusting the window to another person. So that is fraught with the problem of inter-individual variations. So this is the wake-up trial that was published in the New England Journal of Medicine, where they had used the DWI flare mismatch and had suggested that the patients had benefited more, and there were also more the symptomatic intracranial hemorrhage as well, but the overall recovery was better than those patients who were not thrombolized in wake-up stroke. So as we have seen earlier, when there is an earlier ischemia, the cellular energy failure results in the cytotoxic edema accumulating within the cells. This results in absence of movement of water molecules and what is evident as a diffusion restriction. This happens as early as within the first hour. Then the blood-brain barrier disruption happens and there is vasogenic edema, and that's when we see the flare hyperintensity. So the ideal time to address is a DWI positivity and a flare negativity, and this provides us the tissue window and thereby identifying the hidden clock. So in our patient, we have a large vessel occlusion, we have a diffusion positivity, we have a flare negativity, hence we are proceeding to our checklist of what we can do for thrombolysis in these patients. And these are the exclusion criteria that we generally use for a stroke thrombolysis, though we here do not apply the onset of symptoms less than 4.5 hours, because by convention, this patient is out of the window period. So we thrombolized him with tenecteplase. By convention, we use 0.25 mg per kg of tenecteplase administered as a bolus dose. For him, the door to needle time was 45 minutes, including our MRI acquisition. The initial NIHSS was 10. This patient subsequently had an improvement in the power immediately in the next hour, and he was able to lift his leg. So immediately we have a beautiful improvement, and we immediately showed it to the attenders that he is doing well now. And there are two options that we have. Apart from tenecteplase, we also have the alteplase. In fact, that was the first one to have a lot of evidence. That's the traditional recombinant TPA, where we administer 10% as bolus and the rest as infusion over 60 minutes. Whereas on the other hand, tenecteplase has a longer half-life, a single bolus administration, a higher fibrin specificity. And 11 randomized trials had compared tenecteplase with alteplase in more of a non-inferiority trial for tenecteplase with alteplase. And it was found that most of the parameters were comparable between the alteplase and tenecteplase, except for those patients with MRS less than or equal to 1 were seen more with tenecteplase than alteplase, but there was no the statistical significance was marginal. If you see, it was a confidence interval of 1.01, and that 1% is the one that saved it with the minimal statistical significance. The other parameters are the same, comparable between alteplase and tenecteplase. So it's up to the individual to decide which one they use, the tenecteplase versus alteplase. Tenecteplase is more of a bolus, and alteplase is more of an infusion over 1 hour. And for this patient, it was not, it's not always as what you expect in a stroke patient. Sometimes you have turning points as you manage the patient, and it was hope that we had seen, but that was turning into fear. What we saw was his arm dropped completely, speech slurred into near silence, and his NIHS has increased to 12. There was no movement in the left upper limb and lower limb. What do we immediately suspect? Is this patient having an intracranial hemorrhage? Though we have obtained the consent that this patient can develop symptomatic intracranial hemorrhage, which is the case in 6% of the patient whom we thrombolize, we still dread this complication because we are answerable to our patients, and an urgent CT scan was ordered. And I was on my toes at that point in time until I got this CT brain, which was normal, and that I was relieved. There was no bleed, no significant edema that was present. So what are the possibilities now that I have for this patient is hemorrhagic transformation, which I have ruled out with this CT brain. Early edema, which can be present, but is there a seizure activity? But there was no clinical evidence for the worsening. He didn't have a positive seizure phenomena for me to say that that is the responsibility for this negative phenomena. Clot migration possible because we label it to reocclusion of the vessels, or if there is a clot migration. These are the two things, or another embolization that has happened in the short period of time because the patient is highly prothrombotic or embolic in the initial 24 to 48 hours. The last thing that we will also suspect is this a reperfusion phenomena? So what we did to see what happened to the occlusion, we repeated the MR angiogram, but now we found that the vessel was open compared to before. Recanalization was achieved. So what was running in our mind was rather than an occlusion or a clot migration, what was it? A reperfusion injury or a luxury reperfusion. So what we actually did an ASL, this was more of a pseudo ASL that we did. We were unable to perform a perfusion study because that involved the administration of contrast, and we didn't want to do that at this point in time. We did a pseudo ASL sequence, and we found that there was a hyperperfusion. Though what we do traditionally with a perfusion study is we get the CBV, the cerebral blood volume, the cerebral blood flow, and the mean transit time. And with this, we will be able to gauge that this patient has a luxury perfusion. But here we have an ASL sequence which can quantify the absolute blood flow, the blood volume. So this is more of a CBV map in the ASL, pseudo continuous ASL sequence that we get, and that was increased, and that was a parameter that this patient had a luxury perfusion or a hyperperfusion syndrome. If this patient had a disrupted blood-brain barrier, then that would have been a risk factor for a hemorrhagic transformation and worsening of the symptoms to a baseline that was even below what his presentation was. So here we have a hyperemia following a successful reperfusion, and we are able to identify it with a MR perfusion sequence, which is the ASL. There are two MR perfusion sequences that we can administer. The routine MR perfusion sequence that we do is without the contrast, that is the ASL sequence. And the other perfusion study like the CT perfusion, where we require CBV or CBF or mean transit time maps, require contrast administration in CT. And clinical impact is that these patients can have neurological worsening despite successful recanalization and tissue salvage. And what is the prognosis? If I compare it to a hemorrhagic transformation, these patients are going to fare better than those patients who have hemorrhagic transformation. If I'm going to compare it with those patients who did not have a luxury perfusion, then these patients are going to do bad than them. But generally, overall, at 3 months, these patients with a proper rehabilitation, we will be able to get them back on track to the same improvement that they had following the perfusion. And perfusion imaging, just highlighting these facts, the core infarct is going to have all the parameters decreased. The cerebral blood flow decreased, cerebral blood volume decreased, and the mean transit time. These are the 3 parameters that's going to be prolonged. Luxury perfusion, on the other hand, is going to be the reverse of it because we have opened up the vessel. So the paradox of reperfusion is that though we are salvaging the penumbra and improving the functional outcome, there is risk of reperfusion that we have to keep at the back of our mind. And we also have a risk of hemorrhage that we need to address as well. So the post-thrombolysis neurological deterioration in this patient, we were worried of hemorrhagic transformation because that's the case in about 6% of the patients. And the reperfusion phenomena, on the other hand, which can happen in up to 15% of the patients. And generally, these patients can have a proper rehab protocol and improve better. So the hemorrhagic transformation is going to have a hyperdensity in the infarct territory, whereas the luxury perfusion is going to have a more of a minimal edema or no change on CT brain. But the MRI perfusion study is going to help us find the increased cerebral blood volume. And we have 2 phases, the early and the late reperfusion. The early reperfusion is the one that is easy to, that's more common than the late reperfusion, and general recovery with rehabilitation is better. So from despair to hope, again back, suppose thrombolysis, after the initial improvement, we had seen there was worsening to an NIHSS to 12. The first signs of improvement were noted 12 hours later, where the patient's speech improved. 24 hours later, he started lifting his arms against gravity. And the next morning, he had a definite improvement. 2 weeks later, he had minimal residual deficits. And this was the follow-up imaging that we had performed at 24 hours. Hyperemia returned to baseline. So generally in a neurological recovery, what are we looking at is after an acute injury, there is cell death, there is dysfunction, there is loss of function in these patients, and then there is an inflammatory phase that happens. Then as there is resolution of the edema, the patient is going to show improvement, and this is the early recovery, and then plateau at some point in time until if we perform a rehabilitation and we induce plastic changes in the brain, reorganization, then there is not going to be much improvement, and rather this proper rehabilitation protocol can help recover these patients who plateau after an early recovery. So the mechanisms of recovery is the initial phase. As we restore the blood flow, the stunned neurons are going to come back to life. And there is restoration of the connections between distant parts of the brain. That's resolution of the diaschisis. And then there is going to be, as we rehabilitate the patient, induce the plastic changes. What we mean is we are going to increase the dendritic sprouting and increase the synaptic connections and produce new cortical maps away from those cortical areas which were damaged, and recruitment of both ipsilateral and contralateral networks for the recovery of the patient. So 2 weeks later, this patient had an MRS. Though he had a loss of dexterity in the left hand, it did not deter him from doing his normal activities. And he was lifting his eyes back at 2 weeks and woken with a frozen arm. And now he was thawed by the timely thrombolysis. And what this case teaches us is that even in wake-up stroke, we have a tissue clock, which is using the advanced imaging techniques of either DWA flare mismatch or CT perfusion techniques or PWI and DWA mismatch in MRI. Thrombolysis is effective in these wake-up strokes, and not all post-lysis worsening is hemorrhage, and advanced imaging can guide management as well. So these are the wake-up trials, and I'm not going into it because we have one more case to discuss. These are the extent trial, MR witness trial, TOS trial, meta-analysis trial. The extent trial actually showed improvement and benefits of the extended window thrombolysis using DWA flare, but this was not seen with the TOS trial because TOS trial used a dose of 0.6 mg per kg body weight of altiplase, and that was the Japanese trial. In Japan, they use a 0.6 mg because they have compared it to 0.9 mg per kg and found that both are equally effective. And meta-analysis of the trial of all the trials have also confirmed that extended window thrombolysis in patients with a DWA flare mismatch or other tissue mismatches can be helpful. And integrating evidence into clinical practices of utmost importance, and using these tissue windows can help salvage the neuron and help in the recovery of the patient. For extended window thrombectomy, we use DAWN and Diffuse 3 trials for the extended window beyond 6 hours, and this has shown to significantly improve patient outcomes. So we have seen this luxury perfusion versus the hemorrhagic transformation, and the reperfusion injury is because of the oxidative stress, the calcium overload, the inflammatory response, and if there is going to be more of a blood-brain barrier disruption, that's going to result in a hemorrhagic transformation. But what are the challenges is that this accessibility to the advanced imaging of perfusion, diffusion mismatch or diffusion flare mismatch might not always be available in a timely manner, and more inter-individual variations can result in some patients being thrombolized and some being not because of fear of hemorrhagic transformation, because we are answerable to the patients if there's going to be hemorrhagic transformations. Now that we have a tissue window based on images, because now that we know that images are not widely available, especially for the perfusion imaging in all parts of a country, we are moving to an era where we can use blood biomarkers. So what are the biomarkers that are emerging, that are being studied is GFAP, MMP9, and NFL. Soon we'll have data enough using these parameters, using these biomarkers, we will be able to gauge if this patient has a tissue window and will benefit from thrombolysis. So DWA flare are also being analyzed by artificial intelligence and help provide us with the data that this can these patients can do better, and we can personalize treatment. So coming from time window to tissue window is the transformation that we have been seeing from traditional to the current era of thrombolysis. So let's go to the key takeaways. Wake-up stroke should not always be excluded from reperfusion therapy. We need tissue windows. If a patient worsens, it can be due to hemorrhage, it can be due to a reperfusion phenomena, and it's always good to have a protocol in place for wake-up strokes and those strokes who did not have clear onset of time. So this is our patient at 1 week. He sends his video from his home. He's able to walk backward. He's able to walk forward, and this is lifting his arm upward. So in summary, this is the summary slide. Less than 4.5 hours, we can go to do our CT, look for inclusion exclusion criteria, thrombolyze. Beyond 4.5 hours, less than 24 hours, we can look for the tissue window. And if tissue window is positive, then we can treat with IV thrombolysis. And if there is a large vessel occlusion, these are candidates for thrombectomy as well, because if the vessels do not open up, then the worsening can be permanent because the thrombolysis has failed in those patients. Now, coming to another patient, I thought it's worth mentioning this patient in this forum. I titled this patient A Mind Full of Symphony, full of music, but that's only expressed by the whispers of the eye. And if you fail to listen to these whispers of the eye, then forever it's only the eye that will be whispering. A 55-year-old male was brought after being found unconscious on the floor. Last, he was seen normal going to his home in the morning after breakfast at 9 a.m. In the afternoon at 3 p.m., he was found unconscious lying on the floor after breaking through his front door. No known vascular risk factors. Presenting blood pressure was normal, vital signs were normal, presenting sugars 136, and he was referred as a case of seizure as there was some jerking noted in the eye with uprolling of the eyeball, and was administered loading dose of levetiracetam. CT brain was done outside, which was normal, and he presented to our hospital at 5 p.m. So this is our patient. The கையை மேல தூக்குங்க. அந்த கை மேல தூக்குங்க ஐயா. கால அசைங்க பாப்போம். ஐயா உங்க பேர் என்ன? So this is the eye movement that he had, which was noted as seizures because there is uprolling of the eyeball. And what actually gave us the clue in this patient was, ஐயா மேல பாருங்க, மேல பாருங்க, கீழே பாருங்க, கீழே, நல்லா கீழே பாருங்க, மேல பாருங்க, கீழே, கீழே, கீழே பாருங்க ஐயா, மேல பாருங்க, கீழே பாருங்க, சரி சைடுல ரைட் சைடு பாருங்க, இந்த பக்கம் ரைட் சைடு பாருங்க ஐயா, இந்த சைடு பாருங்க, இந்த சைடு பாருங்க, சரி லெஃப்ட் சைடு பாருங்க, லெஃப்ட் சைடு பாருங்க, லெஃப்ட் சைடு பாருங்க, லெஃப்ட் சைடு. சரி மேம். Here was a patient that did not actually have any movements, but he was able to understand to all our commands, but he was unable to perform. He was more in a locked-in syndrome, and this was at 5 p.m. He had reported after last being seen at 9 a.m. to be normal. So here we have a 9-hour timeline that we have seen this patient. So we really don't know when he actually fell unconscious. If it were somewhere close to 3 p.m., then we are within the window period. So identifying this vertical gaze and to be consistent with all our verbal instructions, being totally mute without any motor movements, we were looking for a basilar stroke. So here in the midbrain pons junction, we have a mild diffusion restriction, and we do not have any flare changes. What we can see here in the MR angio is the basilar artery being tapering off and being occluded. And in fact, in the susceptibility sequence, the E-SWAN, we can actually visualize the clot showing a blooming here, this black one here. And so we decided to thrombolize as he did not have any he did not have any contraindications, and we thrombolized with 0.25 mg per kg because of having the difficulty in identifying. We had a door to needle time of 55 minutes, though a standard recommended door to needle time is less than 60 minutes. And this was including our MRI acquisition time, which we usually perform a rapid sequence of DWI flare in that region of where the diffusion restriction is. So our time is literally saved on performing the flare, and we do an angio and a susceptibility sequence to identify if this patient has any bleed, or if this patient also has a blooming in the occipital cortex, because that will help us identify amyloid angiopathy and the increased risk of bleed that might be associated with it. So this was the patient right after thrombolysis. This was 10 minutes after thrombolysis. கையை மேல தூக்குங்க. சரி கீழே வச்சுக்கோங்க. இந்த கை மேல தூக்குங்க. இந்த கையை முயற்சி பண்ணுங்க ஐயா. இன்னும் முயற்சி பண்ணுங்க, வந்துரும். இன்னும் கொஞ்சம் முயற்சி பண்ணுங்க. சரி, காலை மேல தூக்குங்க. சரி, இடது கால் மேல தூக்குங்க. வெரி குட், சூப்பர் ஐயா. So this was his eye finding, his gaze. He had a upbeat nystagmus, and on looking to the left, he had the right adduction impairment and dissociating nystagmus, and that was present on either sides, suggestive of a Webino. And in fact, the initial diffusion restriction that we had seen, that was in the region of the medial longitudinal fasciculus on either sides, and that explains this Webino and the eye upbeat nystagmus in this patient. This was the repeat imaging that was performed, and we can nicely see the basilar artery being opened up. The no clot is visualized in the susceptibility weighted imaging. The DWA restriction, which we had seen initially, the flower changes are seen corresponding, but rest of all the tissue has been salvaged with opening of the brain. This is the patient at the end of about 3 weeks. He had an initial ataxia discharge, but with home-based rehabilitation, his ataxia improved and he was walking normally. His Webino is still present, but it does not impair his activities of daily living, and he is back to normalcy. So closing message is, for years, wake-up strokes meant lost chances, but tissue-based imaging has changed the story. It all started around 2008 and more established in 2016. And this case reminds us sometimes the brain still has time if we are bold enough to listen to the hidden clock buried underneath the neurons. Thank you very much, sir.
Thank you very much, Gugan. It was a very insightful presentation. Both cases are really learning cases. And we learned that, the point you have stressed is that now thrombolysis should be timeless, at least up to 24 hours. The timelessness should be considered. Thank you very much. I open the case for discussion. Let me invite my moderator, my good friend, Dr. Prachet, to take it forward. Prachet, your comments, Prachet.
Thank you, Dr. Sundar. Dr. Guhan, it was a very good presentation, both the cases. The first one, however, I have some questions in the first case. You said he
Yes.
presented with weakness, and what is the power on the left side, left lower limb?
Left upper limb was 0, sir, and lower limb was ill-sustained against gravity, sir. He just could hold it barely for less than a second, sir.
Okay, but with that DWA scan image, can you explain the muscle weakness with the infarct in that place?
So DWA cannot explain, sir, but the hypoperfusion in the middle cerebral artery, that's probably the salvageable tissue, sir. If we could actually perform a perfusion image, we will be able to identify these areas have hypoperfusion, but not yet the cytotoxic edema, sir. So this, if we had performed a perfusion imaging at that point in time, we'll be able to identify the DWA PWA mismatch, sir.
Yeah,
But
definitely correct. So ASL would have helped some more because probably there's chronic occlusion in the right MCA. And then over on top of that, there was some hemodynamic compromise also. And he did not have any neglect, no? He himself complained of the symptoms.
He did not have neglect, sir. And even in that video, he was seen when I asked to lift his left upper limb, he was seen to actually say that I can't lift my left upper limb and lower limb. And though that left side had a wall, he was still aware and he did not have neglect, sir.
Yeah. So again, that's a clue that the parietal lobe is significantly preserved. So clinically itself, we can say that the parietal lobe is clinically preserved. And then I think, I'm not sure, the previous chronic obstruction is one of the risk factors for this hyperperfusion syndrome. I am not sure about that. We'll just check. This and pre-existing malignancy, I think, are the two risk factors for hyperperfusion syndrome. So it's a good case. So we all should be aware of this possibility. And nowadays we are doing more and more out of the window. We are doing thrombolysis. So based on this tissue findings only, so it is becoming more and more popular. And Yeah. And the second case, suppose, for example, you did a repeat MRI. No, when did you do the repeat MRI?
That was at 24 hours, sir.
So, see, the patient initially improved only partially. Okay. So you don't know whether the basilar artery thrombus is still sitting there or
Yes, sir. Absolutely, sir. SMS sir used to tell me that if there is a
So,
occlusion, drip and ship. He used to tell me this
yeah.
because large vessel
So
occlusions.
one way of mitigating that is to do a CT angio.
Sure, sir.
See, you do a CT angio, you'll be very sure. See, in MRI, the problem is if MRI is normal, you can say that there is no significant occlusion. So let's say the repeat MRI you do after some time and still there is some occlusion. You have a doubt whether basilar artery is open or not. So best is to do in such situation is to do CT angio or do a contrast MRI. Do a contrast MRI or a CT angio. If that vessel is still open, then the next step would be to do a thrombectomy.
So usually we have a protocol here of after thrombolizing, we'll recommend for thrombectomy and ship the patient, sir. But
Yes,
this
absolutely.
patient is that because this was strongly on the teaching of Dr. SMS sir, he used to tell me if there's a large vessel occlusion, thrombolize and shift him out. But
Correct,
we
correct.
advised him for thrombectomy, but the attenders were not willing for thrombectomy because they were seeing the improvement in front of their eyes. And though I explained them this could be transient and there could be a worsening later on, but they denied that fact. But God's wish that his vessels opened up, sir.
Yeah, good. Yeah, that's fine.
Gugan, that was really a fantastic case, Gugan, really. I'll tell you, there is one more point, may I point out, Gugan? Now, before
Yes, sir.
the
Please.
luxury we had with all these perfusion studies, when a patient has been thrombolized, this was even before the advent of mechanical thrombectomy. When we thrombolize a person, and then you have an imaging study, the vascular imaging study, which shows the vessel has opened up, but the patient has not improved. Now, as I mentioned to you, these were before the times when he had the perfusion studies. The luxury perfusion, which is actually a luxury only to see the perfusion. So we couldn't have that. So one of the mechanisms that was proposed by Dr. Alexandru et al. We have this paper in 2004 in stroke, wherein patients have been shown to have recanalization, that is early recanalization has happened. But when you see them clinically, they have not yet improved. And the mechanism that was proposed was something very similar to myocardial infarction. We do have patients with myocardial infarction where we actually look at their vessels by angiogram, they have opened up. But when you do the echocardiogram, the regional wall motion abnormality persists. So what they called as a myocardial stunning has been proposed as a mechanism for brain not improving clinically, but radiologically, the vessels have opened up, called the ischemic stunning of the brain. That was one mechanism which I thought was interesting to share with you, in addition to the luxury perfusion, which you so clearly delineated to us using the perfusion studies. Now, for the benefit of postgraduates, we have three mismatches. Before I go on with that, I would like to ask your MCure people, is there another case for discussion or shall we go on with this? If you have a discussion on another case, we have to wait. Hello?
No, sir.
No. Then I can
No,
go
sir.
on with
No
this.
other case to be discussed.
Yeah, then I can go on with this. So in addition
Yes,
to the
sir.
stunning presentation, which Gugan said, so I'd like to point out about, 4 mismatches which we can see. Now, one was what Gugan taught us right now, the diffusion perfusion mismatch. We all neurologists and physicians are fond of this because it is quite easy for us to obtain on both diffusion and perfusion. That is easy for us to do. Very quick, we can do it. The second one is what actually Gugan showed beautifully, I must say, what Prachet also discussed. That is, here is a patient whose diffusion actually is not showing so much of abnormality, but Prachet pointed out that the clinical deficits are much more than what can be explained by the diffusion. In other words, you have a clinical versus radiological mismatch. Even without an MRI, we usually are fond of doing only CT scan in the first 3 to 4.5 hours. When in our hospital, we have protocol that less than 4.5 hours, no MRI. Do CT and do thrombolysis and then sit and think, because tenecteplase, fortunately, we have the advantage that we can do it very quickly. So we do only CT scan before that. And when you look at the CT scan, if the aspect score is more than 6, which means the tissue is relatively well preserved by our imaging studies, but you do the NIHS stroke scale, which is high, more than 10, then we say that this is a clinical aspects mismatch. That is, the clinical deficits are not explained enough by your radiology. This is what was shown so elegantly by Guhan in his MR imaging. In the MRI, the abnormality shown on the diffusion weighted imaging weight was not much, but the clinical deficits were much more than that. What does it mean? Because still we have extensive salvageable tissue. The tissue is going to dilute very quickly. These are patients who will have, if we do a vascular imaging study, we can see a lot of collateral supporting them. And then one mistake that should not happen in these people is to allow the BP to drop. So collateral support and the BP support are going to keep the neurons viable till you can do something. That is exactly what Guhan did. The clinical findings were much more. The radiological findings were not that more. He thrombolized and he had a very good defect. So we have the second type of mismatch, the clinical aspects mismatch. There are two other mismatches. The third mismatch is the clinical core mismatch. You have a core infarct volume which is not correlating with your clinical deficits. Here, you are actually measuring the core. You are not just looking at the images, you are measuring the infarct core volume. And this is exactly what was the basis of the dawn criteria. We had the dawn of a new era. After the entry of dawn criteria is when we were emboldened to go ahead with mechanical thrombectomy with ease. Though we knew that we could do it, we did not have enough supporting evidence. I have to confess to you that 1 year before the publication of Dawn trial, in the same NEJM, there was a publication called MR Rescue Trial. And then following this, which was a failure trial, there was screaming headlines in the NEJM itself that is it really worth going ahead with thrombectomy, which totally changed after the publication of MR clean data. And then came the dawn trial for us, which was dawn of a new era. That's how Medscape portrayed this. So why I'm saying all these things is because the third type of mismatch you can see is the clinical core mismatch, wherein you will have an infarct core volume which is not very high, but the clinical deficits are much more. So you divide these patients based on age, more than 80 and less than 80. In patients who are less than 80, look at their infarct core volume 30 and 50 ml. For more than 80, it is 20 ml. And look at the NIHS deficit and go ahead with your mechanical thrombectomy. That is the third type of mismatch. The last type of mismatch is the diffusion core criteria, which was the basis of the diffuse data which we saw. That is a target mismatch profile. You have a target imaging and there is a mismatch. So they used actually target volume. You have an ischemic volume, you have the penumbral volume, you have the perfusion defect. If the perfusion defect is more than 2 times the ischemic defect, the cutoff which they used in diffuse criteria was 1.8. But roughly for us, for an eyeball imaging, you can always say more than 2. If it is there, you have a target mismatch profile. So there are 4 mismatches: the diffusion flare image mismatch, the clinical aspects mismatch, the target mismatch profile of diffuse data, and the clinical core mismatch of the dawn data. So with these things, now we are more advanced to say that we can easily go ahead and take up the patients for advanced treatment, which could be either tenecteplase or we can go for mechanical thrombectomy. Now coming to the use of tenecteplase beyond the conventional window, we have enough data. The extent data came with the altiplase, and with tenecteplase, we have now strong data coming from the Chinese group, the trace to data, which has been quite favorable. It reinforces our idea that we could advise tenecteplase in these patients, which is exactly what we are doing. The extent data was for altiplase up to 9 hours, but the data for tenecteplase has now been extended up to 24 hours. Earlier, the chapless T data as well as the timeless data were not so favorable. They did not give good outcomes, but the trace to data has given good outcomes. I'm sure this will be replicated in future data. As Gugan was saying, we should not keep on looking at only our wall clock. We should actually look at our biological clock for us to go ahead and thrombolyze our patients. Now, looking at the wake up data, Gugan so correctly pointed out about the wake up stroke trial, which he did not dwell completely. But when you look at the wake up stroke trial data, they did not give a conclusive answer there, but it was followed by several other studies, and which included even epithet data. And subsequently, now the consensus is that when you have tissue to salvage, even in a wake up patients, you can go ahead and actually go ahead for thrombolysis in these people. So these are very good data which you said, and tenecteplase is actually a boon for all of us. Earlier we were using altiplase, nothing against it, but tenecteplase quickens our administration time and eases our process when we take up the patients for mechanical thrombectomy. That is so much good about tenecteplase, and all the latest data is actually on tenecteplase, as was the extend IA-TNK data. Now, Gugan, I have a question for you. When we talked about the mismatch, it is so easy for us to look at the mismatch in the anterior circulation. Even in the posterior circulation in cerebellum, we are much more comfortable. So, what is your take on looking at the mismatch on the brainstem? How reliable it is? Because you showed us a brainstem and you said flare is not so seen. Could you just highlight about mismatch on the brainstem for us?
Yes, sir. Traditionally, the same DWA flare mismatch is more for the anterior circulation, and it's very hard to use it on the posterior circulation, more because the posterior circulation cuts miss on these flare changes. So what we do here is we apply a 0.6 mm cut exclusively only on the brain stem, that is in the region of the diffusion restriction. And if we do not have a flare change, we do explain the patient's attender that this, though, is an extrapolated data, flare change is not seen, and we can take up the patient for thrombolysis. This is also based on the other fact that generally the window for posterior circulation tends to last longer than for the anterior circulation, sir.
Yeah, Professor Lakshmi Narasimhan sir, my unborn young elder brother used to tell us that the MRI could be completely normal in patients who have got posterior circulation stroke in the initial window. So more often we have to rely upon clinical signs, and one of the signs you actually demonstrated to us during an acute window period, you showed us that there could be a patient who has locked in syndrome like presentation so acutely. Most of us are not so astute clinical physicians like you, Bhuvan. We tend to miss, we quickly see and come back. But you have been kind enough to take a video and share with us what was there in that given patient. And then subsequently you followed up and you showed us that there was a webinar. And thank you very much. And one more point I want to stress for people who actually feel inferior when they do not have advanced studies like this perfusion studies. A very important point I want to share for all of them. Diffusion flare mismatch is good enough for our practice. It's more than enough for our practice. Now, looking at the perfusion data, we all tend to have a hype about CT perfusion because you could see all those studies, the Dawn diffuse data, most of them are based on CT perfusion studies, and we might feel inferior if we do not have a software for doing perfusion studies. We need not feel inferior at all. CT perfusion is not a very reliable imaging study at all. This has been discussed in our forums quite often. There are people who are very fond of CT perfusion, but I reiterate my point that it is not a great thing for us to miss. It's nothing something big, extraordinary we have missed because number one, as you could see, it is not available so easily. Number two, when you're doing a perfusion data, even a minimal head tilt, the patients are going to be restless. A minimal head shake will give false images there. And very importantly, in an ischemic zone, it's a dynamic circulation. So the circulation may vary at any point of time within seconds. In the same ischemic zone, you can have sometimes hyperperfusion and marked hypoperfusion. The timing of your images are so crucial. You could be picking up the data when it is hyperperfused, and you might say that there is no perfusion defect, or you might be picking up at a time when it is so hypoperfused, you may think that a large perfusion defect is there. So we may overestimate or underestimate a perfusion study. So the reliability of using only CT perfusion is less. More often, they were useful for study purposes, for research purposes, but for us, for general clinicians or general practice neurologists like me, it's more than enough if we have only a diffusion and flare data. We don't have to really dive our heart out for having perfusion data for CD perfusion or even an MR perfusion. If you have ASL, it's good, you can do it. But I would suggest do not waste time with any of this fancy stuff. Look at the perfusion we use of flare. We are good enough and going and doing it. And believe me, that we have been using these strategies more often than not and finding more successes than failures. Dr. Vijayan, my colleague from Coimbatore, used to say, there is no excuse for not perfusing the penumbra. That's a very beautiful statement he teaches. He quotes from his teacher, Dr. Vijay Sharma. We have to remember that. So let us not worry about this fancy stuff. Diffusion, perfusion, mismatch, go ahead and do it. Of course, less than 4.5 hours, stay with CT, because when you do advanced studies, is when we actually get confused for ourselves and then we go dig deep ourselves, start dissecting out and land up in trouble. 4.5 hours, CT, no bleed lies. Beyond 4.5 hours, up to 6 hours, do an imaging study which will actually show the vascular imaging. Again, don't worry about perfusion data. Go ahead for mechanical thrombectomy. If you do not have facility for endovascular, then you might do these perfusion studies, which, as I mentioned, diffusion flare, or if you have advanced apheresis. Beyond that, to do it 6 to 24 hours, you must actually demonstrate the salvageable penumbra to do it. That point should be clearly remembered. We can't be bold enough to say we don't have perfusion data, but still we could do it. But remember the caveats behind using perfusion study straight away. These are the points I thought I will share. If Prachit is there, I will have to ask one more question from you and this one. If this case is over, I would like to put in one more case vignette, which I would like to share and take the house.
So your voice is muted, sir.
Okay. Can I go ahead and just put one more case for you to see? Just a question I need to ask Mugan. If we have a recent stroke, which was hemorrhage, say within 3 months ago, a large basal ganglionic hemorrhage, can we thrombolyze this patient when he comes for ischemic stroke within after 3 months? Rachit, what is your take on this, Rachit?
No.
3 hours, 3 months ago, hemorrhagic stroke, basal ganglionic hemorrhage, completely recovered.
Okay.
Can we thrombolyze this patient with tenecteplase?
Now, what was the presentation? The same area of stroke, Dr. SMS?
No, I'm going to come back to the presentation, Balu. First, this data only, just the first question I want, because there is a hidden catch behind this. So a patient has been treated for basal ganglionic stroke, recovered fully. Typical gangliocapsular hemorrhage, maybe around 30 to 40 ml bleed, I can say. He has come and can he be thrombolyzed?
Why
I'm
not?
going to tell you
Definitely.
why I'm asking this question.
Yeah, we can do thrombolysis. Why not?
Yeah, I believe so, because the patient in question I am quoting is a surprise for me, because I got to see as a referral from the cardiologist this patient. And why is he under cardiologist? Because he has come with acute myocardial STEMI, ST elevation myocardial infarction. He has received 0.4 milligram per kg body weight of tenecteplase. And I have seen him subsequently, because the patient had previous stroke, I am seeing him. Patient is spot okay. And now he has been taken up for angioplasty, which he has undergone angioplasty. So we have been always been taught that basal ganglionic hemorrhage, a large hemorrhage, 3 months, do not thrombolyze. And I also follow that. Prachit, I am following that. But this is a case which has opened my eyes, which was there 4 days ago. I've seen this patient 4 days ago, and not 0.25, 0.4 milligram per kg body, which makes me think, are we doing the right thing in rejecting patients for stroke thrombolysis when you could get away with this? What is your comment on this, Balu?
Oh, sorry, as you had seen the case, and then we have to all the trials has safely excluded the patients. So even if you look at the trials that we had earlier discussed, also pregnancy was excluded. Now people say that yes, you should do thrombolysis in the pregnancy. So similarly, these are the things excluded unless we report individual case reports after 3 months. It's a possible. And when we had a bleed, and then we never started even the anticoag. Now we can say that after 24 hours to 40 hours, you can start low molecular weight for your DVT. So earlier, what was the opinion? So after seeing individual case reports and reports by you people, and definitely I think you should do that. So why hemorrhage is a contraindication even after 3 to 4 weeks? I'm not going with the 3 months. So 3 weeks, I'm saying that after 3 weeks, I'm not going with 3 months, 3 weeks. Why it's contraindicated? So we have seen patient having hemorrhage, developing DVT. We have seen patient having hemorrhage, seeing MI. Even before discharge. So the thrombotic phenomena is happening. So that a bleed has happened. The chance of bleed is high because already there is a blood-brain barrier damage has happened. So there's a reason that we are worried. Blood-brain brain barrier breach was there. There's a reason we are worried. So when it closes, actually, at beyond what time exactly we can redo or we can do thrombolysis, that we don't know at present. We don't know exact timeline. I think 3 months is a reasonable time. So I'm waiting people to say 3 weeks. That's my guess. Yes, over to you, SMS.
Thank you, Balu. That's my thought as well. I thought 3 months is a reasonable time for a psychiatrist to form and be strong enough that it may resist hemorrhage. So we actually have to rethink our strategy. This was the eye opener for me. This case was an eye opener for me because if they had asked me from the emergency, can we thrombolyze, I would have said no, don't do it. But I was asked on the next day, 24 hours later is when I got to see this patient. And I was stunned when I saw that. The patient incidentally has been discharged yesterday. 4 or 5 days he was admitted, he has been discharged, he has gone home very well. So it strengthens our notion that antiplace can be administered in patients who have had recent hemorrhage or maybe a remote hemorrhage without really, confining ourselves and excluding them, constraining ourselves and excluding them. Maybe we should have a rethinking of the strategy. Gugan, what is your take on this, Gugan?
Sir, the only thing is that it was similar to my second patient, sir. Only thing is that posterior circulation might not identify. So when talking with the attenders, it was more like, if this patient bleeds, then will I be on the safer side? That is the only question that needs to be answered. So it's like that is telling them the data that though there is no approval because we don't have data, but we do have case reports that patients have been saved. And those scenarios where the deficit is really worse, like this in this patient, he would have forever been in locked-in syndrome if we had not taken that step of thrombolizing him. Though I told them that there is definitely a chance of bleed, but if we don't take that step, then we might lose him forever to locked-in syndrome. So if the deficit is severe enough, then definitely we can take that bold step of thrombolizing the patients, because we are moving more towards smart thrombolizers. And most of the exclusion criteria here are not evidence-based, but rather expert recommendations, sir.
Prachit, your take on that, Prachit?
See, as Balu said, it's a question of blood-brain barrier only. So we are worried about blood-brain barrier breach only. I don't know, maybe this was just a one-off case which escaped. I don't know, maybe I'm skeptical, I don't know.
This escaped me, Prachit. Fortunately, they did not call me and ask me before. It escaped me. And because of that, the patient is okay.
SMS.
Happy they didn't take my advice before.
SMS, one question that people started using our connective of 0.25, 0.2, and then high dose, low dose, similarly 0.9 of altiplase and 0.45. Was there any trial in cardiology side, connective 0.4 versus 0.2?
Yeah,
Why
see,
are they
I
used
do not
still
know.
0.4?
No, I do not know. But the thing is that the rough criteria is that 2/3 of brain cardiac dose should be used for the brain, because of the simple reason that we have a higher instance of having hemorrhage. A myocardial infarction does not have a differential diagnosis of myocardial
No, no,
hemorrhage.
we
But
know,
there is
we know
no,
that means that are they giving more dose? My question is
no,
that
no, no,
with
no.
0.2, with
Actually,
0.2 itself,
all
whether
these,
will it open?
I'm sure there would have been data. I do not know about the myocardial data.
Okay.
For any drug to be brought into the market, they would have to do the dose escalation trial. For example, of tenteplase, 0.2, 0.3, 0.4, 0.6, all four were checked before they reached the 0.25. Before there is a 0.2, and then 0.2 and 0.25 compared, the ACT trial came up data. So
Okay.
all these things will have to undergo the dose escalation trial. I'm sure MQ will be able to provide us with the data and the cardiology, but neurology I'm aware 0.2, 0.3, 0.4, 0.6, and in fact, for some time in up to date, when you open it, they would be putting 0.4, then tiny place is not useful, and then you see down the admission 0.4 was given, there was risk of hemorrhage. Nobody is using 0.4. This was even around 3 years ago. I pointed out to them that I know why they are actually giving a negative publicity. 0.2 is very useful. Put that no, they would be given the negative publicity there. So 0.1, 0.2, 0.3, 0.4, 0.6. This was the trial tested. And then 0.2 became approved. And now between 0.2, 0.5 something is going on. I'm sure for myocardial infarction, they would have done this dose escalation studies. Maybe MQ people can answer that. Do you have data on that, sir?
Next meet we can put that data. Next meeting we can put the data as that. So
Yeah, it should be there
why
for even
why
for
this?
any of even for a dabigatran which use 110
Yeah,
BD,
we know
150
that.
BD, 220 BD, everything is there for us. So there should be data for that also, Balu.
Yes. Sure. Thank you, SMS.
Prachit,
Thank you.
any
Thank
other
you.
people want to contribute? Sir, MQB, can we close the data? We had a good session. I'm sure our audience learned immensely from what Gugan taught. Gugan gave a beautiful lecture on the use of tissue window rather than the time window, which is the need of the hour. I'm sure I will be taking more points from Gugan and I'll be implementing in my practice. Thank you so much, Gugan. As usual, brilliant.
Very
And
good,
thank you,
sir. It was
Prachit,
just
for
returning what
moderating this and giving
it
your.
was just returning what you had
Huh?
taught us, sir, and you're teaching
Yeah,
us,
yeah.
sir.
Is incisive, and then presenting in front of Prachit is not an easy joke. Me and Balu
Yeah.
will accept. Prachit will not really.
Yeah.
Incisive will be.
Yeah,
Isn't
yeah,
it,
yeah,
Balu? We are
yeah.
nice. We
Tough, real critic, and then he pours a lot of inputs. Like he pours a lot of inputs, and
He
Gugan's
poured
slides and the way he presented, the way which he took us,
beautiful.
really nice, really nice, excellent, Gugan. I enjoyed.
Gugan,
That's it.
Gugan, if Prachit has said it is good, it is really good. I know that very well.
Thank you very much, sir.
Thank you. MQ, we can just close, I think.
Yeah.
Your closing
Bye bye.
remarks.
Thank you.
Thank you so much, everyone, for this enlightening session. Thank you so much for joining in. And it was a pleasure hearing all of you discuss these case studies, sir. So thank you so much, everyone. Good night.
Thank you, sir. Thank you.
Right.
Thank you.